Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. My name is Dr. Iftikhar and I am working as spine fellow in Lahore General Hospital. Today I will discuss the role of PLDD for prolapse intervertebral disc. Ladies and gentlemen, PLDD means percutaneous laser disc decompression, and it is used for disc protrusion, that is the back pain. As we all know that back pain is number one problem in orthopedic OPD as well as in neurosurgery. There are many causes of the back pain, but one of the cause is prolapse intervertebral disc. It can be treated with activity modification, or sometimes we have to add the analgesia, and in some cases we also advise physiotherapy to the patient. Very few cases need surgical intervention for prolapse intervertebral disc. As you know that all the patients have some fears and phobias about surgery. They are reluctant to put the knife on their back, especially around the spinal cord. People now want very small incisions, microcuts, and cosmetic scars instead of having massive incisions, big cuts, and exuberant scars. Crude and cumbersome instruments have been replaced by the less traumatic and sophisticated gadgets. Ladies and gentlemen, tubes and trocars have pushed out the huge retractors and divers out of the operation theater. Now patients always demand minimal invasive surgery, and PLDD is one type of minimal invasive surgery for disc protrusion. This study was done in our hospital, Lahore General Hospital, and we started this study since January 2022, and in this study, 100 patients, we done this procedure, and we have to wait about 15 months to complete this data. We included the patients who have back pain due to disc protrusion and age between 20 to 60 years, having radicular pain for more than 4 months, and who have exhausted the conservative management, that is analgesics. We excluded patients who have non-contained nucleus pulposus, that there is tear in the annulus. It is very important because if annulus is not intact, the PLDD will not work. PLDD will work only if this annulus is intact. If balloon is ruptured, then PLDD will not work because it evaporates the water contents of nucleus pulposus, and if it is tear, PLDD will not work. So we excluded the patient who have tear annulus. We also exclude patients who have previous surgery at the same level, neurological deficit patient, patient who have infection at the local area, and pregnant females we excluded. Patient who has mechanical instability at the local level, we also exclude these patients. Patients who are agree for this procedure and they qualify the inclusion criterion, we take the formal consent from them, and then all the pros and cons were discussed with the patient. All the routine investigations were done, especially the MRI and pain severity VAS, visual analog scale, was measured. There were 100 patients and 54 females and 46 males, and patients who have age less than 40 years were 44, and who has more than 40 years were 54. Average age of the females were 43.9 and male 42. Radiation of the pain on the left side was 52 and on the right side 48. As far as the duration of the pain is concerned, we divide into 3 groups: more than 3 years 56%, 1 to 3 years 38%, and less than 1 year 6%. This is the level of disc protrusion. Mostly patients were L4, L5. This is the VAS scale. which is from 1 to 10, and roughly we can divide it into mild, moderate, and severe pain. This is the data. Pre-procedure VAS score, 8% patient has severe pain, 84% has moderate, and 8% mild. Then 1 week after the procedure, 4% severe pain, 20% moderate, and 36 mild, and 40% was free of the pain. After 1 month, when we assess this patient, 2% has severe pain, 14% has moderate, 24% mild pain, and 60% has no pain. After 3 months, 12% has moderate pain, 18% mild pain, and 70% were happy with no pain. And after 6 months, when we assess this patient, 11% having moderate pain, 19% has mild pain, and 70% were free of pain. This is the laser machine, and this is the kit. We see here, it is the laser probe, and it is attached with this tube. We attach this tube to the laser machine, and this is 3-way valve. One of its end is attached to the trocar, and other end we put this laser probe into it. The third hole, we put this tubing with it, and this tubing is to see the evaporation which are coming out from the disc. This is the laser end. You see here, this is the trocar is inside this disc, and this tubing is outside. We are putting this probe inside this trocar into the disc. This is the trocar. This is trocar. This is the probe. And this is the procedure, how we do it. All the condition and all the procedure is like GA surgery, that open surgery like disc removal. We put the patient on the operation theater prone, and then put the sheets, scrub, and offside is applied. Then we mark the level. For example, in this patient, we have the disc L4 and L5. This is the K-wire, the metallic indicator. We put it on L4, L5. We check it on C-arm. This is AP view, and then we check it on the lateral view. This is L4 and L5. This is the sacrum. This is L5. This is L4, and this is we are attacking on the disc L4, L5. Now we infiltrate at the local side, but on the posterolateral side, because we are going to attack from the posterolateral side. This is patient lying. Here is tummy, and this is the back. We do not go from vertically here. We go from here, oblique, 45 degree. 10 centimeter from the midline, we are going to attack on the disc from posterolateral side. Local infiltration, then trocar insertion. Then we have to penetrate the annulus. Sometimes we have to put local anesthesia in the annulus because it is sensitive, and pain ending are here. This is the laser tube. This is procedure is done. And we have to see the position of this trocar. When we put trocar, sometimes it can go up or down, but we have to target at the level where we want to put this trocar. In AP and lateral view, we have to confirm. And it should be in the center of the disc. You see, L4 and L5. This is lateral view. We see in the center. Yes, it is in center. And we confirm it that when this tip is touching to this spinous process in the midline. We see this is touching the midline, and in the lateral view, it is in the mid. So we put the laser in the midline. of the disk, because if we put it on near the disk, it will burn the disk and there will be discitis and erosion will be occur. This is lateral view. This is L5S1. It is difficult to put in L5S1. This is lateral view. This is L3, L4. Lateral view. Lateral view. L3, L4. And the message is that we should put the trocar in the center, both AP and lateral view. It should not touch the end plate. How it acts? All we know that nuclear process contains the higher amount of water contents. And whenever we put the laser, it evaporates the water content and the disk shrink. When it shrinks, its size is reduced and the pressure on the nerve is decreased. So this protruded disk cannot cause its pressure on the nerve and pain is relieved. It has also other mode of action, but that is less important. That heat changes the protein nature of the nuclear process. It promotes the angiogenesis. It improves the immune function and normalizes the autonomic function. This is the discussion. In international study, we can compare it. Gromyer has 75% good results. Masoud and Hashim has 87% results. Shoy and Asher 78%, and Shivert 78%. Agarwal of India also claims good result, and Shank of Netherlands says that there is early rehabilitation and low complication rate. This is another reference. This is the reference. This is MRI before and after PLDD. So the take-home message is that before going to surgery and after exhausting the conservative treatment, we should have this PLDD. Thank you.
What is the difference between the outcome?
We do not compare these results with ozone, but with endoscopic and open surgery, it has the equal results. But it has benefit that number one, there is no general anesthesia required in this procedure. Secondly, it has only the needle or the trocar which are going to put in the disc. There is
18
no
gauge,
blood loss,
18 gauge or 16 gauge needle you put it.
no blood loss, no structural damage. All this benefit from the patient, and patient can go home on the same day. On MRI, we can confirm that annulus is intact or not, because it is the baseline for this PLDD. If it is tear, there is no benefit at all for PLDD. Yes, whenever there is a tear and disc is prolapsing or extruding or sequestrating, it is contraindicated. We should not do this because it is closed hydraulic system. When it is closed, we can evaporate the water outside. If it is not closed, water is not evaporate and there is no benefit.
Is PLDD still effective in patient with lumbar canal stenosis with narrowing, very narrow diameter AP, or we using other modality is best if the diameter has narrowing?
Yes.
And also in patients with lumbar canal stenosis, is PLDD still effective for pain, sir?
Yes. We have done this study on the lumbar area because lumbar disc is larger as compared to cervical and the thoracic, number one. Number two, whenever the disc is short, that is called osteoarthritis of the disc degeneration, then results are not too good. If disc is degenerated, results are not as good as in normal disc. If it's a hydrated, normal high disc, results are good. There are 4 points. Number one, age of the patient. If age is less, good results. Number two, one level disc, good result. Number three, disc is normal. It is not osteoarthritis of the disc. Results are good.
Thank you, sir.
Yes, disc height is preserved. It means there is no osteoarthritis. We compare the upper and lower disc with the diseased disc. If disc level is low, that is narrow disc, it means some osteoarthritis there. We can do here, it is not the absolute contraindication, but results are not too good.
It's expensive, iPhone is expensive.
Yes, Pakistani 80,000. Yes, only this machine and this instrument. Surgeon charges and all are.
Good presentation, Dr. Iftikhar.
Thank you.